So shoulder problems are very common. It's the third commonest orthopedic complaints you see in your practice. 1% of adults will see the GP each year for shoulder problems. Historically, the shoulder is said to be the unanswered joint. Typically, injections will be thought of when you see somebody with shoulder pain. There are actually at least 118 tests you could do on the shoulder. We're all very busy people, and there isn't enough time in primary care to do all these tests. So I would suggest then we try and narrow down these 118 tests to just 4 based on what we think are common things. So shoulder diagnosis is quite easy. Based on age, based on a tiny bit of history, you get a good idea what you're facing against. The easiest age group with the young patients, 16 to 25. In that particular group, impingement is almost impossible. We're looking at things like trauma, usually as a result of instability. So the shoulder dislocates last year, it's dislocating over and over again. Sometimes ACJ disruption as a result of an acute injury. In the elderly age group, again, it's quite easy to have a good idea what's going on. By and large, the commonest thing is rotator cuff tears. Probably about 70% would be rotator cuff, 20% or so of arthritis, and 10% mixture of the two, in which case that's known as cuff tear arthropathy. The ones in the middle are more tricky. It could be any of those things. It could be frozen shoulder, calcium, cuff tear, arthritis, labral tear, and for that particular group, we need accurate history and examination. So if I could recommend to you 4 basic clinical tests for shoulder examination, I think if you do them well, you should get the diagnosis quite easily. First one is external rotation. We'll go through each one in turn. Second one is the Job's test, which tests for the rotator cuff. Third one, the Yoakum's test, which again is for the rotator cuff. And lastly, rather than using any eponym names, we just go by abduction external rotation. So, external rotation is actually more tricky than you think to detect a loss of external rotation. Remember, there are only 3 reasons why somebody has a loss of external rotation on the painful side. Most commonly around here, frozen shoulder. In an elderly person, arthritis in the glenohumeral joint is another possibility, and very rarely a locked dislocation which has been missed. Remember, if somebody has more external rotation on the painful side, then rather than frozen shoulder, is actually a cuff tear. So it's a cuff tear involving subscapularis. So this is the painful side. Notice that the torso is tilting as you try to passively externally rotate. Compared to this side, freely rotates. So we're looking at not the range of rotation in the forearm that you can turn outwards, but there to look at the characteristic tilt of the torso when you're trying to externally rotate. It's about pattern recognition. That's another one. This is the good side and now the painful side. Sometimes it takes a few turns to get the results that you want, which is actually partly pain and partly a loss of external rotation there. So this is a rare one. If you've seen an elderly person who has fallen over a few months ago, no fractures were seen in A&E, but they're not rotating. Think about a locked posterior dislocation. So there are 2 ways of testing external rotation. You can do this like we did earlier on with him standing, yes, and then you can see the characteristic tilt. In a very muscular or well-padded person, you may wish to lie them down. The scapula is now held stable by the couch, and therefore just trying to turn the forearm down, it doesn't come down. So there are 2 ways of testing external rotation. The second test, which I recommend, is the Job's or MT can test. This is for the power of the supraspinatus. So essentially, the arm needs to be turned in internal rotation to neutralize deltoids. So thumbs down, otherwise it's the MT can test. The arm will be brought forward a little bit in order to line up with the scapula, hence 30 degrees from this plane. So you do an MT can test, you ask the patient to put it there and resist upwards. This is a very good test for the rotator cuff, but to supplement that, I recommend the Yoakum's test. So the bad side, you put the hand on the opposite good shoulder, the elbow is asked to push up. Again, between the Yoakum's and the Job's, you get a very good idea what the rotator cuff is doing. That's the 3 tests already so far. If you believe in odds, if somebody's age over 60, has weakness in external rotation, they've got a painful arc, drop arm sign already, there's a 91% chance of a cuff tear. In an older person with instability, think about why the shoulder is coming in and out all the time. Most likely there's a very large cuff tear involving the anterior stabilizing structures, which is subscapularis. And in that case, they've got more rotation passively. So that's all I want to do as a fourth test. So the arm is abducted, externally rotated. We're not looking for apprehension, we're looking for more pain is the predominant issue. This is frozen shoulder. You've got a humeral head here, long head of biceps, labrum, rotator cuff, very red, very inflamed and rather tight and can't really get into the joint. So it's rather a red, angry, inflammatory, painful condition. This is glenohumeral osteoarthritis. You see a big osteophyte here. For that reason, there's a loss of external rotation and the patient cannot rotate. Remember, arthritis comes as a spectrum. Sometimes on the plain X-ray, it's reported as normal, but you can still get more subtleties of arthritis. It could be like this. There's a big chondral lesion here. This would be painful, and the patient wouldn't want to externally rotate. This is the young person with recurrent dislocations. You see the humeral head here, fairly much destroyed glenohumeral joint, big Hill-Sachs lesion. That's the cartilage lost from there, and the debris is all collecting in here. For that reason, there is no external rotation. It could be like that, little loose bodies. Remember, if you see a little loose body there, it's going to come from somewhere. So somewhere is missing that little piece. Sometimes it could be like that, somebody doing some chin-ups and then felt something snap. It's actually more like a shear fracture through the chondral cartilage. In a contact injury, you can have a bit of glenoid articular labral disruption. So basically, there's a piece of cartilage which has come off the glenoid surface as a result of a high-speed, high-collision injury. So what is a slap tear? We keep talking about slap tears and labral tears. So you have the humeral head, you have the socket. The labrum is a piece of cartilage that lines the joint. So that little piece there is prone to injury, prone to tears, and prone to problems. So if the tear happens at the top, where the long head of biceps sits, that is otherwise called a slap tear. It just means there's a tear of the labrum at the very top of the shoulder joint. Because the long head of biceps is still attached, you get the pain. So this is a bucket handle tear of the superior labrum. I guess you can't really see that well from where you are. Humeral head, glenoid, that would be the superior labrum. This is long head of biceps. So imagine you did lots of cricket bowling, tennis playing, then after a certain time with an acute injury, this would just rip and tear like this. So this is what's called a slap tear. Happens commonly with this type of mechanism of injury. Can be a lot of repeated bowling, fielding, all those things would be prone to this. Now, that's a slap tear. A slap tear, the shoulder does not dislocate, but sometimes you have a tear of the anterior labrum, the front of the socket. In that case, if this is torn from here like so, in a young person playing sport, the shoulder will come out again and again in the long term. So what do we do if we have to do something? We would actually repair this piece of cartilage back onto the socket using these little micro pins. So essentially it's a case of tying some stitches on top of the labrum to recreate this buffer effect, like a speed ramp. So at the end of the surgery, you go around the clock, do as many as you have to do until all that tissue is repaired onto the glenoid and therefore restore stability. So these pins are more old-fashioned ones. There are some much newer ones now, whereby the design is much better. Historically, we use a plastic pin, which dissolves after about a few months. Nowadays, we use purely a soft tissue pin. So with this, there's hardly any bone loss in there. The drill would be 1.4 millimeters rather than the conventional one, 2.8, and therefore it's much bone preserving, much less traumatizing to the body. But equally, you need more of these to get an evenly distributed repair. So principles are quite easy. This is the labrum, come off bone. You really have to put a loop of stitch around there, tied on top like so, until that labrum is repaired to the glenoid. So this is before. You can see just about from where you're sitting, there's a glenoid. There's my probe. The labrum is widely displaced, and after you put some finer stitches around there to repair that labrum. So shoulder impingement is probably the commonest thing you will see in primary care. This is the godfather of shoulder surgery. He described impingement about 40 years ago, and he suggested that if you were to remove a bit of spur from there, that would help with the mechanics of the shoulder, allows the rotator cuff to function better. So true impingement is actually dynamic. It's actually not something that happens during sleep. It's actually more something when you have pain, when you use the shoulder doing overhead activities. This picture is quite rare to find because they can see a proper evidence of impingement. There is a crack along the top half of the tendon, and they can see a spur. As you move the arm, you see the two touch against one another with friction. So this is an X-ray of a young person. On this X-ray, there is no bone spur. I don't see any. I'm sure you don't see any. If you believe in bone spurs, take more X-rays like that. You can tilt it up, tilt it down. Eventually, you can convince yourself that there is a spur. So what I'm trying to say is that impingement is not as common as we think. Certainly in a young person, I would avoid making that diagnosis. The other thing to avoid making diagnosis of is ACJ osteoarthritis. It's actually just part of aging. If you look at the studies here, probably majority of us in this room are more than 30, and therefore 93% of us would have ACJ osteoarthritis on the X-ray, but very few of us actually have symptoms. So this is actually part of an aging thing rather than the cause of the pain. So remember, look for bruising. If somebody has bruising along the front of the arm, something is fractured, and usually, if not, a major muscle tear. Rotator cuff rarely bleed, labral tears do not bleed, so this is actually a biceps injury. Popeye bulges that comes in different shapes and sizes. You must find out, is it a proximal rupture or is it a distal rupture? Proximal rupture happens in an older person, distal rupture in a very muscular guy, and it's an acute injury that needs urgent repair within a few days. Pec major rupture, again, very common in bodybuilders. They go to the gym and there's an acute snap. If you see somebody very, very muscular, lots of bruising, don't really find anything else wrong, assume it's a pec major rupture, send to A&E. In a young person, after falling over onto the side, they may have a step like this. This will be ACJ disruption. Majority goes to A&E, one or two will come to primary care and see you. So this will be an injury to the side of the shoulder after falling over. So this is the more tricky one, the ones whereby they will come and see you repeatedly, one day after another with severe pain, and that commonest is in women. That kind of age group, 30 to 60, commonest diagnosis would be frozen shoulder, calcifying tendonitis. So my first suggestion is that you do an X-ray for somebody with acute severe pain in the shoulder and look for calcium. Sometimes it goes from smaller to bigger, and these ones are usually quite painful. In the acute phase, the calcium was first picked up. It's usually very custody, very fluidy. This is the rotator cuff. That's the my needle going in. You can see the calcium is pressurized within the tendon. Once it's decompressed, the pain is a lot better within a few days. In the chronic sense, once this has been there for a bit longer, the calcium is more like a creamy toothpaste consistency, a little bit harder. In the long term, it's been left for months and years. Eventually, it's more chalky, like plasterboard material. It's not true that the bigger the calcium, the more painful things are. It's actually when it's building up acutely, then you get more like a pressurized effect within the tendon. Once this stuff is squeezed out, it's good. If by chance you give them the injection of steroid in primary care, as you put a needle in, just by chance the needle went to this calcium deposit, some creamy stuff comes out into your syringe, carry on aspirating. They'll be very thankful once you can withdraw the calcium for them. So frozen shoulder, that's another one which is very, very common. The diagnosis seems to be rather vague, but in fact the description from 80 years ago is still probably the best one. Remember, frozen shoulder is not actually in the shoulder joint, it's actually in the arm, around the biceps area, but also around the back, because the scapula is tilting as a result of lack of external rotation. So you have pain over the medial border of the scapula, very common with frozen shoulder. Sometimes you may find that the affected side, the scapula, sticks out, and you're thinking a nerve problem. It could be, but more commonly, if the shoulder is stiff, this is actually part of the frozen shoulder presentation. There'll be tenderness at the front, where the rotator interval is. There is the little bone here called a coracoid. That little ligament here is where the disease process starts. So that area of redness is where the pain would be, and tests for frozen shoulder is not really helpful. MRI scan would be best. Sometimes it doesn't go away because of tendon tears. It may be after an operation. If it's after an operation, then usually the only person who can unlock the shoulder is the original surgeon. Diabetes, if it's badly controlled, it doesn't get better. Some people ask and say, why does these tears not mend themselves? You look at this picture here, I'm pulling on it quite hard in order to bring the tendon back to where it was. So if there's a combination of arthritis and rotator cuff tears, this is called cuff tear arthropathy. What it means is that the ball has risen up, there's no tendon, and afterwards the only treatment for that would be a reverse polarity replacement. We've listened a lot this morning to hip and knee replacements, and I think historically the shoulder replacement has been thought to be experimental, movements are not very promising, but in fact if you select the right patient, if you do the correct operation, there can actually be much more movement than you think. However, it's not a good idea in somebody who uses the arm a lot, if they're wheelchair bound, if they've got a nerve problem, if they've got not very good bone stock, it's not a good idea. Last few words about injection. We can talk more once we come around the table, but basically, why do some injections work and some don't? The main reason is the correct indication. If you do that for arthritis, it's quite difficult in there in the first place, probably won't work. For an acute injury, probably won't work. Once you're sure you know that you're correcting the right reason for injecting the shoulder, then think about where you want to place it. Do you want to place it in the subacromial space here? This would be good for rotator cuff tears, for calcifying tendonitis, for impingement, or do you want it here, which is a glenohumeral joint, and that's for frozen shoulder, glenohumeral osteoarthritis. After that, think about how you're going to give this injection. If you use an orange needle, a blue needle, it won't get you where you want to get to. You should use a green needle, probably the longer one. In a very muscular, padded person, think of using a spinal needle, even longer. Expectation. You must tell the patient what to expect. It's not going to cure the world, it's just a bit of short-term relief, and then knowing when to stop. It's no point continuing over and over again. If the first one didn't work, I would be hesitant to do the second one. You may want to refer it on to the secondary care, maybe either assessed by a consultant or perhaps injection by guidance. Thank you very much.